Hey guys, so one of my friends asked me to kind of talk about how to survive intern year. So now, we're like 10 months into intern year. So I do have a couple tips for you all in terms of how you survive. Maybe not how you shine, but kind of have to make through it. So first of all, when you are on an inpatient service, it's probably one of the busiest rotations you will have. So in the first few months, you do have to be there early, unfortunately. No one gets efficient from the get-go, so it takes time to build up the efficiency. So what you can do first is with the existing patients on the list, you and your other interns or residents who are supposed to split the list, you guys can talk about who you're gonna pick, and then you can read up on those patients ahead of time. So that will save you some time the next day in the morning when you have to cram all the new patients and trying to learn about the new patients, and we'll try to look up the old patients. So that's a tip. So in terms of the patients, so on the day of the rotation for inpatient service, so on the old patients, which you hopefully know a lot about, you know their top three diagnoses, and you need to know what really is keeping them in the hospital. So are we waiting for blood culture to be negative? Are we waiting for them to be afebrile for 24 hours? Are we waiting for IV antibiotics and transitioning to PL? We need to, or are we waiting for, input or recommendations from the consultant? So you kind of have to know what's really keeping the patients in the hospital. That way you can always work towards, what we can do to get the patients out of the hospital. So that also includes, which sometimes gets ignored a lot, is disposition. So unfortunately, a lot of patients are too sick to go home, or there's not anyone in the family to take care of them 24/7. So what you need to do is put a consult to social works, put a consult to PT and OT. So PT and OT will do their evaluations, and they will recommend, say, intense PT up to 5 or more than 5 times a week, and that will, that statement itself will qualify the patient for a SNF, which is like a skilled nursing home. So that way you can take that recommendation to the social worker, and they will work on finding a SNF placement for the patient. The key is to do it early, because it takes time. It takes time for insurance to approve the pre-authorization. It takes time to arrange transportations. There's a lot that goes into getting the patient out of the hospital from not just a medical standpoint. So that's something you need to do early on. So in terms of day-to-day stuff, so you get there, hopefully if you have Epic, there are some buttons you can push that will print the entire, print all the labs, print all the medications they're on, because I do see a lot of my co-interns spending like an hour trying to write everything down. There are people who are on like 20 different medications, and it's a pain in the butt to write everything down. It's a pain in the butt to write all the labs down. So what I do is I print like a summarized page with labs, with medications, with kind of like a sign out blurb about the patient's past medical history, what they're here for, and then I will circle whatever lab is abnormal, so it's much easier, it's much quicker. And then what you need to do is, for the old patients, kind of write down the labs, write down more imaging, anything like that. And then go see the patients and see what's changed, figure out the top 3 diagnoses and stuff that keeps, or top 3 problems that keep the patients in the hospital for now, and then come up with a plan in terms of fixing those problems. But for the new patients that you get overnight, or got it handed off to you in the morning. Not only need to look at the lab since the mission, like what's going on with the patient, what are the problems, but also you kind of need to look at the old studies based on patient's diagnosis here. So if someone has a heart failure, you need to look at the echo, right? Even if the patient doesn't have an echo now, like what's the echo from, say, 3 months ago? What medication, in terms of heart failure medication they're on, what has been changed? There are patients who got admitted just because they failed, or so, like the outpatient heart failure medication titration, and then what else you can do for them? Say if they have a new EF of 20%, you just start talking about pacemakers, defibrillator, and that kind of stuff. So, or like if someone come in with chest pain, so have they had a recent stress test? Have they had recent heart cath? What kind of, have they had a cabbage? When was that done? When was the last cath report? When was the last strep? When was the last echo? Those pertinent information, even though they may not be obtained in this admission, but go back and look. That's the beauty of electronic medical records. But the downside is you would find yourself spending a ton of time doing this. So another thing that can be complicated is our cancer patients. Patients that get diagnosed with cancer, so you need to dig into, especially breast cancer. I find that pretty, because they do have long survival, so you need to go back, hey, when was that diagnosed? What stage was it? Was it triple negative? Was it ER positive? PR positive? What medication they have been on? Did they have lumpectomy, radiation, chemo, or they just had a mastectomy? So all these stuff, you kind of need to sort out, because some of the attendings would want to know. But in the same time, you're always, as an intern, you're always balance between trying to be thorough and trying to be efficient. So that's a lesson. Well, that's something I'm still trying to work on myself. It's really hard to keep everything straight, per se. Especially, we have a service that people just dump patients on our list in the morning, so we don't really get a handoff from the residents. They were just dumped onto our list, and some of them, have been here for 200 days and try to figure out what happened. Or there's some of them that were ICU transfers, so you have to go back to the notes and see what happened in the ICU. They were tubed, they were lined for what? They were in septic shock from what? And count, how many days of antibiotics have they done? What kind of cultures they have grabbed? What has grown? Because you need to figure out how many more days of antibiotics you need to give, how many more days of prednisone taper, and yada yada yada. So another thing is sometimes it's helpful to check with the nurses and see what happened overnight, but that can be tricky because at least in my hospital they switch shift around 7, so that's usually the time when I finish reading up all my patients, writing down the labs and circling the labs that are abnormal. So this is tricky because they are doing their handoff and you feel like you're interrupting them, but sometimes you have to. Oh, and the other thing is, if someone has tele heart monitors, you need to look at tele, especially if someone came in with AFib, RVR. You kind of want to look back on the tele and see, how long, were they actually rate controlled, or were they actually in AFib? Were they actually intermittently back to sinus and then back to AFib, or they were in AFib the whole night? And if they were in AFib, what's their heart rate? And then any other abnormal rhythm on top. Sometimes people come in with AFib/A flutter. They're just going in and out, like A flutter, sinus, AFib, sinus, A flutter. So you kind of have to figure out what's going on overnight if they have tele. So, and then like you do pre-round. This part is actually pretty quick. You should spend, I honestly think a lot of us spend more time reading about the patients than actually talking to the patients. So you will do your exam, kind of do a review of system, ask them what's going on last night, what has happened, anything changed. You have to kind of target towards the chief complaint that they came with. Sometimes patients distract you a lot, but they get distracted and talk about other stuff, but you kind of have to redirect them because you really do not have the luxury of spending half an hour with them every day when you have 8 patients or 10 more patients to see. So you have to direct them really, and then do a pretty thorough exam. And if you have seen them before, it's better to it's good to compare the exam findings, like especially I like heart failure. So heart failure people, they were like 2+ pitting edema, and today's 1+, or where JVD is up to the ears the day before, and today is maybe lower to the jaw maybe. So you want to compare these to see if you made any progress. And the other thing with heart failure, you always want to look at eyes and nose. So you want to know, are they net positive, net negative, how much they were net positive or negative since admission. That's very important. So, and then you round, make sure when you round, ask your resident. Most times they work with that particular attending before, so you will know the style, because everyone's different, unfortunately. Some want very complete, very thorough presentations. Some want to just be, to the point. The patient came in with acute exacerbation of heart failure. We started on IV Lasix, 18 milligrams TID. Today is day 2. He has been net negative 3 liters. He felt better. Shortness of breath has improved. So this is a plan. I'm planning to diuresis him a little bit more, and then transition to PO, possible discharge tomorrow. Things like, it can be really quick, but someone might want very, very formal presentations, which, can take time. You just have to be systematic about it. This patient has medical history of, ischemic cardiomyopathy, acute or chronic systolic heart failure with reduced ejection fraction last EF 20%, history of COPD, history of chronic respiratory failure, 2 liter at home. You have to present all those past medical history, and then come back with, so the patient presented, 3 days ago with increased shortness of breath, orthopnea, and swelling, found to be in acute exacerbation of heart failure. So patient, and you go by, subjective, like a SOAP. So subjective, patient thinks she felt better, she's breathing better, swelling's been better. Objectively, here are the vitals, here are the labs, here are the physical exams, here's the EKG, here's the eyes and nose, blah, 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 blah. And then assessment, hey, here's a 54-year-old, blah, 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 history of blah, 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 presented with acute exacerbation of heart failure. So for the plan, assessment plan, problem number 1, this is acute exacerbation of heart failure or acute on chronic half-breath. They like the ERP, so etiology is due to, say, medication non-compliance or diet non-compliance response. He had 2 days of 80 TID Lasix response. What's the response? He put out like 6 liters, right? He's like net 4 liter negative now. And plan, our plan is we transition him to PO 80, TID today, or PO 80 BID, observe him for a day, and then possible discharge tomorrow. So for problem number 2, chronic respiratory failure, it's not in exacerbation, no exacerbation, continue home O2 supplement. Number 3, I don't know, I can't think of anything, like history of coronary artery disease. We continue beta blockers, we're going to continue the Cineprol, we're going to continue aspirin. If they have recent stent, maybe continue Plavix too. So if someone wants something really really formal, so it's different. You just have to cater what your attending wants.